Our next speaker is Professor Peter de Jonge from Groningen University, and Peter is a Professor of Developmental Psychology and a Professor of Psychiatric Epidemiology at Groningen. He's involved in the World Mental Health Survey. In fact, he leads the comorbidity group, and I'll be a member of Peter's group over the next few years as we maybe try some of the things that Oligar's developed in Danish data on World Mental Health Survey data. Peter actually has been in Copenhagen for the last few days at the Philosophy and Psychiatry meeting that Ken Kendler and Joseph Parnas have been running. So it's great that you're in the country and we could steal you up here to present. So Peter will show you data from the World Mental Health Survey that Peter and I and Christian and Harvey work with Ron Kessler at Harvard. This is a confederated data set of over 30 surveys that are administered for the Harvard Medical School. And this taps into the gaps that we cannot see in the Danish registers. So these are door knock surveys of people that don't seek help as well. So Peter, please tell us a little what you found. Thanks very much.
Thanks, John, and thanks for inviting me here and for organizing this. I'm having a wonderful time listening to all these talks. I hope the same with you, and I hope this will not change after mine. Let's see, I'm going to talk about the structure of mental health, and I couldn't have wished for a better introduction to what I'm going to present by what Oliver just presented. This is more or less the situation before. This is normal, this is okay, don't... Oh, it's okay. Yeah, that's part of the joke. So, this is what was in how psychiatry looked like before there was DSM. And then DSM came up, and then you see slightly some light at the end of the tunnel, and we began to think about specific discrete disorders. If you take, for instance, major depressive disorder, if you look at DSM or ICD, it more or less looks the same. What you see is they identified core symptoms and additional symptoms, and there are all kinds of decisions made how to operationalize such a disorder. And the idea was to reduce heterogeneity across the different complaints that people have, but what you can also see is a lot of heterogeneity remains, because you have 227 different profiles that fulfill the criteria of major depressive disorder, which is okay, but just it's not perfect in reducing all the heterogeneity between people. You can ask all kinds of questions. I had a psychometric training, and you can, as a psychometrician, you can think about, why did they distinguish between core symptoms and other symptoms? Why did they use a sum score? Why did they have a cutoff at 5 and not 6 or 4? Should we use a cutoff score at all? Why not rumination? Well, because rumination is already in GAD, but have you ever seen a depressed person who doesn't ruminate? All these different kinds of things you might think about depression. Also, how can one single disease produce opposite symptoms like hypersomnia or insomnia, and weight gain or weight loss? Those things are pretty difficult to answer. Of course, the answer is that this is a consensus definition, and a consensus definition is not perfect. I'm also not going to say that it doesn't have any worth, but it's not perfect. So what John just said, I came back from a philosophy conference, and I didn't dare to show this, but to a group of non-philosophers I do. You could think about psychiatric diagnosis as describing the reality, but for instance, you have outside, you have the sun, and everyone believes that the sun is something real, right? It would exist even if we weren't here to think about the presence of the sun. However, there are also things in life which are really constructed by humans, and some of them do not exist if there weren't any humans to think about them. And psychiatric disorders are on this continuum. And maybe it's a little bit on the constructivist side, but I'm not going to tell you that psychiatric disorders are just inventions which are having no link to reality. What you can say is that it's a bit like a pragmatist view or a conventionalist view. You have to have some kind of classification in order to think about phenomena. And that was exactly what DSM was meant to do. Before that, everyone would think differently about the kind of diagnosis that you would get. So one way of looking at psychiatric diagnosis is that any psychiatric classification system should have the form of a falsifiable hypothesis or something that is actually work in progress. The goal is to create categories of people that is within such a category is relatively homogeneous. So if someone has a depression, then he might benefit from an antidepressant. But if someone else with a different symptom profile that still fulfills the criteria of depression would also benefit from an antidepressant. Those kind of things you want a classification system to do. Well, if you look at depression in particular, depression is probably one of the most problematic diagnoses because there is so much heterogeneity. And for instance, what we showed a couple of years ago is we had a sample of 267 people with a major depression, and we did 12 repeated CD interviews in a 3-year period. And we, at each period, we counted the number of DSM symptoms that a person would have. And what you see is initially people would have 6 symptoms. That's normal because that's the definition of depression. And then it goes down. After 3 months, there is half of the people have a recovery of depression, but you also see that there are some residual symptoms. That's the official language about how to describe depression. Duration of approximately 3 months, residual symptoms, but this is all based on averages. If you look at individual trajectories of persons, it looks like this. So within this category of depression, there is a lot of heterogeneity in the course. So if someone comes to John, for instance, as a doctor, and he says, well, I have a depression, how long am I going to be depressed? Then the best answer would be, well, between 0 and 3 years. And to be honest, I don't know for sure on what side you are going to be. It all depends on additional factors. And that's not so nice. It is even a bit more worrisome if you look at the effects of antidepressants, which is 0.35 Cohen's D. Then you see some people respond, some people do not respond. These are data from the FDA, where we selected many subsamples of each of 100 people who either got an antidepressant or a placebo. And this picture is the same across all subsamples that we did. It is very difficult to retrospectively find out who got the antidepressant or the placebo, because there is so much heterogeneity across people. On average, there is an effect of antidepressants, but you still do not know for whom it's really going to work, for whom it's really not going to work, for whom placebo is going to work, and for whom placebo is definitely not going to work. That is not an ideal situation. And the claim that I would like to make in this talk is that maybe we should take the diagnosis a bit less serious and get rid of the idiosyncrasies that surround those specific diagnoses. So, talking about diagnosis, when I was talking with a colleague of mine a couple of years ago, that was in 2005 more or less, we observed that every different version of DSM included more disorders. So what we did was a regression analysis on the number of disorders being predicted by the year. And so we predicted that if the DSM would come out in 2010, there would be 454 different diagnoses. We were a bit wrong because it came out in 2016, 15, and there were only 400. So they managed to bend the line a bit. But still, we have more and more psychiatric diagnoses. So it is sometimes a wonder that not everyone is going to have a mental disorder in his life. The question is, do we really need 400 disorders to describe psychopathology? Well, I don't believe so. For instance, if you look at the effect sizes associated with SSRIs and SNRIs, you see an overall effect size, Cohen's d, of 0.3, 0.4 for major depression, but also for generalized anxiety disorder, also for panic, also for social anxiety, also for PTSD, and also for OCD. Maybe that says something that these disorders are somewhat the same, and maybe we should not distinguish between them on a diagnostic level. Diagnosis is meant to direct treatment, and if the treatment works equally well for across diagnosis, then maybe there is something wrong with the diagnostic criteria, or the diagnostic categories, I mean. Okay. Now, coming back to basically to Oliger's work, I did the same kind of analysis in the World Mental Health surveys. So, in the World Mental Health surveys, we have data from 35 countries across the world, and all people were administered the CD interview to determine the presence of mental disorders. And this is the table of odds ratios for having one disorder and another. And what you see is basically the same what Oliger showed, that all disorders are correlated. But you can also see some are more correlated than others. And, well, some classical and well-known ones are between major depressive disorder and GAD. But you can also see specific phobia, agoraphobia, conduct disorder, and let's see, where are we? ODD. Those are pretty well-known correlations. Some of them are stronger than others. And there are people who have argued that this pattern of comorbidity is actually informative of the latent structure of psychopathology. And already in 1999, Bob Kruger did a factor analysis on mental disorders, and this is basically what he found. There are internalizing disorders, MDD, anxiety disorders. You could make a further distinction between them, between anxiety actually and fear. So fear is the really acute panic reaction, while anxiety or misery is more when you think about it, and it comes slower. And on the other hand, there are externalizing disorders, such as alcohol and drug abuse and dependence, and well, in his case, antisocial personality disorder. So the first model that he showed, you can see that there were only 3 disorders included in that model, and that made it a bit problematic in a way. What about OCD? What about eating disorders? What about bipolar disorders? What about ODD? What about intermittent explosive disorder, ADHD? They were not yet included in that model. Slowly, this model developed over time, and sometimes a bit inconsistent, but at least the difference between internalizing and externalizing has been the most clear, and perhaps also between or within internalizing, the distinction between fear and anxiety is also relatively well confirmed. So, well, about 20 years later, and I apologize for the quality of this slide. I'm not so good in these. Some people are good in that, but I'm not. Anyway, what we did last year was a kind of replication of Kruger's work, but then with 16 different disorders. And we kind of confirmed his model, where we found, for instance, that ADHD is also should be seen as externalizing, well, that this was stable across different countries, high-income group countries, low-income group countries. So that's quite reassuring. What happens if we include other disorders in it, like eating disorders? Well, eating disorders should be seen as a distress disorder. What should we do with psychotic experiences? In the World Mental Health Survey, we don't have psychosis, but we have psychotic experiences. They form a separate factor. What to do with bipolar disorder? In accordance with most of the literature, it should be seen as an internalizing disorder, but it wasn't clear if it's a fear or a distress disorder. At least it's more on the internalizing than on the externalizing. So we have a relatively stable model, and I was actually pretty happy that we could confirm most of the work that Bob Kruger and his colleagues did. Now, what is the use of it? I mean, it's nice to have these factor models that take about 2 weeks to converge and blah, 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 but there is also a use to it. Bob Kruger originally said this about the structure of mental disorders. Maybe those factors, or what he said was, comorbidity results from common underlying core psychopathological processes. These results argue for focusing research on these core processes themselves, rather than on their varied manifestations as separate disorders. So maybe these latent factors represent some kind of vulnerabilities that have different expressions in episodes. Well, that is what I kind of made of it. Perhaps these underlying psychopathological processes represent the elements we are actually most interested in, without the idiosyncrasy associated with many of the individual disorders. And maybe we could view them as lifetime vulnerabilities of which the disorders are just manifestations. And I should clarify this a bit. So I'm basically a professor of psychiatric epidemiology, but 2 years ago I moved to developmental psychology. And I did so because I was more and more concerned that we should aim for preventing mental disorders, because if we have them already, it's maybe too late. And if we can prevent it, maybe a disease process has not really yet been going on. And so I told the university that I wanted to become a professor of developmental psychology, but only if I could redefine developmental psychology, not as child psychology, but as the part of psychology that is dealing with the development of people over time. And I had some sources saying that this was actually what developmental psychology was originally meant to do, so they agreed. So that enabled me to do some research about this possibility that maybe these underlying factors are some kind of lifelong vulnerabilities. For instance, you are born as a stress-responsive child. You have a high risk of specific phobia. You don't have the tools yet to worry so much about it as adults do. To become depressed, you have to be, well, there are very little number of children actually becoming depressed. They undergo the very stressful experiences, but only a very small minority of small children become depressed. Adults, on the other hand, have this talent much more developed, you could say. So if we go to the World Mental Health surveys, what you see is there is huge variation in the median age of onset of disorders. So specific phobia has the lowest median age of onset of 8. And you can also see in the externalizing disorders that conduct disorders and oppositional defiant disorders have a much lower median age of onset than, for instance, drug abuse or alcohol abuse, because you're only allowed to use that when you're 18 or 21 or whatever. So maybe those disorders are just early expressions of the same things that could happen later on in life. So I wanted to present the same factor model, but then using longitudinal data, but I got some other data last week, and I decided, also inspired by your idea that we should present a big ID. It's sketchy, but I think it could be very interesting. Suppose you start with the specific phobia, because it has such an early age of onset. And we zoom into that one. Then you can see that there are people who have different subtypes. So you can have a fear of heights, you can have a fear of animals, you can have a fear of lightning, you can have a fear of blood and injection things. There are all kinds of different subtypes. And I was thinking, if you have just one subtype, fear of heights, that's pretty normal. If you have two, well, it becomes a bit more difficult. But if you have 3 or 4 different of those subtypes, then I'm pretty much convinced that you are someone who is quite stress sensitive. And what you see is there are many people who have more than one subtype. What I then did was I looked at lifetime comorbidity of those people. And first of all, I selected the people who had this specific phobia at the age of onset before 13, so at primary school. And then I looked at what happened to those people when they were adults. And what you see is, across all these different internalizing disorders, you see a very clear linear gradient where people who have no specific phobia have very low prevalence of those disorders, but people who have more than 4 have very high comorbidity when they are adults. And the same as when you look at disability, you see it going up, but also very severe mental outcomes like suicidal ideation, suicidal plans, or actual suicidal attempts or gestures. And maybe that's because those people who have more than 4 specific phobia subtypes are the ones that develop all kinds of comorbidities during their life, which are in the end so demotivating to continue with their life, or they just accumulate so much comorbidity during their life that those are the people we are very interested in to identify at primary schools. Because they have a substantial risk of having these very severe negative outcomes. Almost there. I see some possibilities there. If we can identify a phenotype early in life with a high risk of lifelong consequences, perhaps then we can prevent psychopathology and do real primary prevention by analyzing what is actually going on with those people, showing that some people are more stress responsive than others, and that there are ways to deal with that before there is a real disorder. I mean, specific phobia is still something that is relatively in the normal area of life. I mean, who isn't afraid of spiders? Who isn't afraid of heights? Who isn't... Everyone can talk about it in a non-stigmatizing way. And maybe that will give a way to address those issues in children already and to prevent all these nasty things going on later on. And maybe we can fine-tune those phenotypes with registered data. I would be very eager to do the same kind of analysis together with you guys on the registered data, and also to see if we can identify such phenotypes without the idiosyncratic things that attach a little bit to the specific disorders. So maybe we can find a phenotype of children with a risk of internalizing, a risk of externalizing, psychotic experiences, and I believe that is what I wanted to say. Thank you very much.
Okay, we can see we have an expert here. Peter, it's really good for you to follow up Oligar's work, because you live in this realm of psychopathology and trying to find latent structures. I really respect that. Questions for Peter from this discussion?
Thank you for that very elegant talk. So my question is about treatment, and I very much agree with sort of your point about thinking beyond diagnostic classifications. And so if we think about the example of specific phobias, often the treatment is actually very specific to the phobia, right? And it's about exposure, for example.
Yeah.
So do you think that maybe is too limited, and that in fact the treatment should be actually sort of broader to encompass the larger risk?
Yeah, well, that's a very good point. Maybe I'm pretty hopeful that in the beginning of such an internalizing phenotype, that it's still specific and linked to something specific. So CBT, for instance, is highly effective for specific phobia, but the more it becomes detached from specific things, the less easy it becomes to treat it. And the more you generalize it across different domains of life, also the more difficult it becomes to treat it. So I believe that maybe by showing young children already, if they are afraid of something and you can overcome that, you create also some kind of thing, well, if I can overcome this, maybe I can overcome this too, and that you create a kind of dynamic where children learn to deal with their stress responsiveness.
A world expert in the front row here, Marietta Nordentoff. And so Australia and Denmark are setting up headspaces, and we're trying to attract young people in the earliest phases of non-specific psychopathology, trying to do what Peter's vision is. But do you want to talk about or share with us your thoughts about, do you think the headspace model will be a way that can capture these early developmental prodrome phases?
I think Headspace is one of several initiatives that allows a possibility for people with unspecific or conditions that cannot be called illness yet, and it's also a variety. Something could be being afraid out of school. It's a lot of different issues, but I think to have a broad entrance into, and it's not always an entrance into mental health services, but it can be a way to guide people into mental health services. That's valuable.
So I think that's really important, what we're talking about right now. But a specific question with respect to the GBD. So one of the things that we've got on our to-do list, which we may drop after your talk, is the issue of what's called in GBD dependent and independent comorbidity. So the whole of GBD with the comorbidity adjustments are built on independent comorbidity. So the risk of having another disorder is independent of the risk of having a second disorder. That's never been true for mental disorders, and obviously we've got that in spades right now. And so we were going to move down the path of dependent comorbidity for mental disorders with other mental disorders and mental disorders with physical health disorders. Based on what you've said and what Olga's said, should we put on hold the idea of trying to deal with dependent comorbidity within mental disorders? Because we don't know whether the disorders exist in an entity like the classifications which are in DSM, which underpin the whole epidemiological base of the GBD. So doing a comorbidity adjustment for someone who has an anxiety disorder and a depressive disorder, is that worth doing at this stage? Big question.
Yeah, that's a really good, fascinating question, and I think I could make up an answer that takes me about an hour. I don't know if we have that time. Yeah, so there are a few things that go through my mind. One is that, of course, this relates also closely to RDoC, where they say, well, you know, DSM is wrong. We need to make phenotypes that are not only based on phenomenology or symptoms, but where there is a clear biology attached to it. Well, I don't particularly agree with that. I mean, that's fine, but I think we can already go a long way using the kind of data that we have already. So the point that you make about independent or dependent comorbidity, I did quite some research in the past about the association between depression and heart disease. And there is an association there, and people are pretty convinced that it exists. And it's interesting because the age of onset of depression is about 30 years of age, and the median age of onset of heart disease is much later. So maybe you can use depression as a way to prevent heart disease from occurring. So by activating people, by doing things that are better for them. And so in that sense, I view depression as much more associated with a global burden of disease than what is coming out of the global burden of disease studies. Because you cannot, you don't, well, as you said yourself, you cannot die from depression because that's not on your death certificate. But what happens if you, because of your depression, you sit inside all the time, you do all kind of things that are bad for you, you continue smoking, you drink, and because of that, you get a heart attack and die from that. Who is to blame? I would say depression is to blame from a public health perspective. And we should do something about the depression in order to prevent all those nasty things.
I think we should definitely look at what Olga's presented and what Peter's presented, because we've got a bucket load of data here, and we should do it ourselves. We shouldn't wait for permission from GBD to do it. So we'll talk about new DELIs or new YLDs. And Harvey was saying, should we try to get comorbidity structured in a more representative way in wild-type humans? And I think we should, because it'll definitely predict YLLs. If you've got exactly 1, exactly 2, exactly 3, 4 or more, you are going to die proportionally earlier and you'll have YLLs. And that's just all blurred away in this kind of imputation game where they do the unconditional probability. So I feel like we need to speciate with a different range of DELI type measures, and we should do it within registers and then World Mental Health Survey and see what difference it makes, and then make recommendations to GBD. So we know that they have constraints about what type of data they have access to as well. Any final questions for Peter? If not, okay, please join me and thank Peter very much.